Good afternoon, everyone. Good afternoon. Welcome to FAAB's webinar titled, Does It Really Matter? Examining the Impact of Accreditation on Population Health. My name is Keith Coleman. I am the Vice President of Communications and Public Affairs at FAAB. I will be your host for today's session. We have a packed agenda today, starting with a brief overview of the research findings from our presenters. Amy Belflower Thomas and Dr. Mary Davis, who will share key findings from recent research on the COVID-19 study. This will be followed by a panel discussion moderated by our president and CEO, featuring insights from the panelists. We will open the floor to questions, and we'll answer as many questions as possible, where you will hear directly from the presenters as well as the panelists. Again, we received a number of questions in advance of today's webinar. If we do not get to your question, we will send out a list of questions with answers as well as a recording of today's session. So with that, I am thrilled to turn it over to our presenters. Amy, take it away.
Thanks so much, Keith. I'm thrilled to be here with you. I'm Amy Belflower Thomas. I'm our Senior Director for Research and Evaluation at FAAB. And we're really excited to speak with you guys today about some recent evaluation work that we've been doing. So I think most of us in public health either love or hate logic models, but this is a FAAB's logic model that we use to really look at the impact of accreditation and make sure that we are having standards and measures and our other resources really lead to impact in public health departments as well as their communities. And so, as you can see here, pretty complex model. Early in our days at FAAB, we instituted surveys internally at 5 different stages of the accreditation journey for health departments that kind of answered some of the proximate and some of the intermediate outcomes. And this really gave us some information on the impact of accreditation that we could share. But obviously in public health, we want to really move more towards the ultimate outcomes and seeing the effects and the impacts on things like population health outcomes. And that's why we're truly excited to come here today to share some of this work where we've been able to get to some of those ultimate outcomes in our logic model. Next slide. And so, as I mentioned, if you're a data guru and you get really excited by today's information, but you want to see more data from FAAB that we do have and we're happy to share, we do an annual value and impact report, which again is based on those 5 surveys. And you can see the 5 different parts of the accreditation journey that health departments answer and respond to our surveys. It has a new look and feel this year, and it's going to be released very soon. So that will be coming out widely. But that's always a place where you can find information on some of those intermediate, proximate outcomes and impacts of accreditation. Next slide. But again, we were really excited to be able to have an opportunity to start doing some evaluation specifically around some of those ultimate outcomes. And won't go through each of these, but these are the main questions that we pulled from our logic model and our research agenda that we really wanted to answer with some of our evaluations that we were able to start last year and are continuing this year. So in these, you can see things like contributing to differences in public health outcomes and things like that. Also, ROI is often brought up. That's something we're looking at more of this year. So really exciting that we're entering a stage with FAAB where we do have a lot of health departments who have not only become accredited, but re-accredited. And so we have a good mass of health departments where we can start to look at some of this evaluation information that people are ultimately interested in. Next slide. And so what that led to was wanting to see those ultimate outcomes. We had an opportunity with our CDC cooperative agreement funding to support 3 impact evaluations last year. They were from a period of performance of October 20th of 2023 to this past May of 2024. And we're now being able to discuss them. And so we were able to actually put out for RFP 3 different evaluations that we were really interested in. One was telling the story of the accreditation journey in Ohio. So Ohio is the only state in the nation that legislatively requires FAAB accreditation for all their local health departments, and they're pretty far along that journey now at this point. And so we were really excited to receive many responses and proposals to that RFP, but we did select the Health Policy Institute of Ohio. We were really excited that they applied because they know the context well in Ohio and have been very involved in that. And so this was really kind of a case study specifically looking at Ohio, and it was able to help us with some things like social return on investment and helping us kind of think about what categories and contributors we may want to put into that, and also just telling that story in Ohio, from the health departments currently in process to the ones who have already been accredited, and kind of the differences in perspectives versus maybe some state legislators or other state officials as well as local health departments. And so we do have that report, and it's been shared widely in the state of Ohio, but that report is available as well. The second evaluation was highlighting the experiences of small tribal and territory or freely associated state health departments with accreditation. And we have always been interested in small health departments and thinking about how they can be different with capacity and ability to funding, things like that, to be able to successfully achieve accreditation. And so we have done quite a few evaluations over the years from small health departments, but this one specifically focused on our new version 2022 requirements, standards, and measures, as well as our new pathways recognition, which we thought a lot of small health departments might be interested in. And so this was an intensive case series of 4 health departments, 2 of those being tribal, 1 being a district health department, and 1 being a single county health department of less than 50,000 population, and really looking at their process with pathways in version 2022, and really defining barriers, how they overcame barriers, their suggestions for other small health departments, things like that. And so really interesting work coming out of that. We do have case series documents for each of those, as well as reports that kind of pull all the information together. So I'm sure we'll be sharing that information soon with the accreditation world as well. And that work was done by the Prevention Resource Center at WashU in St. Louis with assistance from UAB School of Public Health. They did a great job with that work. And then the third study, which is why we're here today, is really getting at those population health outcomes. And so we had kind of, it's hard to do population health outcomes evaluations, specifically around things like infrastructure and accreditation. It's hard to tease out contributors and what's directly related or causal to accreditation and things like that. So it's always been difficult, but COVID-19 really did provide us kind of a natural experiment to be able to look at some outcomes. And so we were really excited about this one last year to really give us some population health outcome information related to accreditation, and that's what will be presented today. That work was done by the Emory School of Public Health, specifically their Program Evaluation and Quality Improvement Center. And just want to note that, again, we really appreciate funding by the CDC and our cooperative agreement to support this work, as well as some work we're doing this year as well to continue our work to kind of get to those proximate outcomes in our logic model. All right, next slide. So with that, we're really excited to talk about the impact of accreditation on the COVID response evaluation. Just do want to really emphasize that there is work that supports this, that made us kind of think about this specific line of evaluation. So there was a work done in 2018 by the Florida Department of Health that talked about how their accreditation preparation helped with their Zika emergency preparedness and response to the Zika virus in their state. We do know from a FAAB internal survey that we did during 2020 of our accredited health departments. We did ask about the effects of COVID, and more than 80% of respondents did state that they believe that accreditation helped their response to the COVID-19 pandemic. And then most recently in 2022, a study by Brosi and Mays on early mortality rates during the pandemic associated with communities with stronger public health capabilities, having fewer deaths. And so we know from all of these that accreditation and having strong foundational capabilities really can impact health outcomes. And we're really excited to kind of test that with some COVID-19 data. I do want to credit, before I hand off, also, as well as myself, Britt Lang, who is one of our senior research specialists, for coordinating a lot of these 3 studies and helping our evaluators along the way. So I want to give credit where credit's due with that. But at this point, I will quit talking and we will get into the juicy part of the data. So I want to hand this over to Mary Davis. Mary has over 30 years of experience in public health applied research and evaluation. Specifically for this project, she served as a lead evaluation specialist with the Program Evaluation and Quality Improvement Center at the Emory Centers for Public Health Training and Technical Assistance. So with that, I'm really excited to pass it over to Mary.
Thank you so much, Amy. And I'd want to take just another second to express my appreciation to FAAB for its partnership on this work, specifically Amy and Britt, who Amy already mentioned. They've been day-to-day partners on some days in getting this work done. I'd like to acknowledge all of the authors on this work from Emory Centers, Nikki Ryder, Amar Rashid, and Shankar Bhatt, as well as Britt, and also recognize the funding that supported this work. Next slide, please. So here's a brief outline of what I'll be covering today. And I do want to let you know that we do have a journal publication that's a forthcoming article, and we'll have lots more of the details. I will go into some details of our work, and hopefully we'll have time for questions about that later if you have them. So I'll go back just a second and review some prior studies, talk about the background and research work. I'll tell you about the variables that we included and excluded from this study and why, the analysis we conducted, our results, summary, and the implication and recommendations for future research. Next slide. So before I begin, I want to just kind of go over a little bit of ground that Amy talked about, because I think it's really ground setting for where we are today. As Amy mentioned, this work came out of the COVID-19 pandemic, and given the audience for this webinar, I don't need to go into the details of what we all experienced with that. But I do want to recognize that for more than 20 years, the federal government has invested considerably in state and local health department, territories, and tribes in both preparedness and public health infrastructure. And while we have seen some improvements in things like vaccinations, medical countermeasures, some of these improvements have been isolated and resulting in minimal positive, sustainable change for the public's health. At the same time, the federal government has also invested, as well as other organizations have invested considerably in public health infrastructure through initiatives such as the National Public Health Performance Standards and the development and implementation of the National Accreditation System through FAAB. So we have had lots of investments that have been the stage setting for this work. Next slide, please. And as Amy has mentioned, previous research suggests that health departments that have achieved accreditation through FAAB demonstrate improvements in infrastructure, including capacity building and capabilities related to preparedness. And I just wanted to take a second. Amy did a flyover of that logic model, and many of you may be familiar with the accreditation FAAB's standards and domains, but I do want to call out specifically that domain 2 focuses on preparedness, and other domains including workforce development, partnership facilitation, and quality improvement and evidence-based decision making. These are throughout all the domains of the FAAB standards and measures. So there is a direct connection between the health departments preparing for accreditation to improve policies, procedures, and partnerships to achieve these standards and measures that could potentially lead to improvements in infrastructure, as well as hopefully population health outcomes. Next slide, please. Amy mentioned a few of the specific studies that have looked at the connection between performance improvement and accreditation preparation and improvements in capacities and capabilities. I won't go into each of these in detail as Amy talked about them a little bit briefly, but I do just want to recognize that there has been prior work in this area that sets the stage for our study. Next slide, please. So now we'll talk about a little bit more about background and talk about our specific research question. Next slide. As we know, the COVID-19 pandemic placed an extraordinary burden on and emphasized the critical role of state, tribal, local, and territorial public health departments to protect the health of the citizens they serve. And while there's growing evidence that accredited public health departments have enhanced capability and capacity to address these threats and hazards, research is lacking on the relationship between achieving accreditation and better community health outcomes. And I'll just pause here and say I became involved with FAAB in 2005 since its initiation, and this question has been coming up ever since then. So I'm glad that we actually can get to this. So our research examined whether accredited public health departments had better COVID-19 community health outcomes, specifically around vaccination rates, hospitalization rates, and death rates. So that's what we're going to focus on in this presentation. Next slide, please. So we're going to talk now about the variables that we looked at, those that were included and excluded from this study. Next slide. So our dependent variables or our outcomes include the percent of vaccinated adults by county, hospitalizations per 100,000 population, and deaths per 100,000 population, both of those due to COVID and, of course, COVID-19 vaccination. And you have the definitions there in front of you for these specific variables. Next slide, please. Regarding the independent variables that we use, first of all, we started with a series of time periods. We thought it was very important to break down this study into time periods based on the availability of vaccines for COVID-19. And you can see that we had a limited vaccine, wide vaccine, limited booster, and wide booster availability time periods. For FAAB accreditation status, we created a categorical variable defining local health department status. And I'll just stop here and emphasize our results. This study focused on local health departments, and I'll explain why in a minute. We use the categories of accredited. They received full accreditation from FAAB, in process, meaning there was either in the system beginning preparation or had not been awarded accreditation, and not accredited, not at all in the FAAB accreditation system. And we work closely with FAAB staff to create these categories to be meaningful categories. During the time period that we used, 49 health departments did become accredited. They were counted as accredited for the entire time period. We also use Community Vulnerability Index. This builds on CDC's Vulnerability Index and adds epidemiologic risk factors, public health and healthcare capacity, and variables capturing high-risk environments. Next slide, please. We also included 2 additional variables that really got at the state level environment regarding public health and policies around COVID-19. We created a categorical variable defined as permissive or restrictive state policies around COVID-19. This was based on the governor's political affiliation as of 2020, as of the 2020 election results. And we defined permissive environments as states with Republican administrations and restrictive environments as Democratic administrations. And we did some examination on this particular variable and found it to be pretty sensitive to what we were wanting to get at. The state public health governance structure, which has been included in many studies, was based on the NACCHO 2020 profile. We use the decentralized, centralized, shared, and mixed categories. Next slide, please. The variables that we excluded included other types of health departments. State health departments, 42 of 50 had been accredited at the time of the study. So we found that limited variation, and we didn't have sufficient data on tribal and territorial health departments. We looked at using the COVID Community Vulnerability Index versus CDC Social Vulnerability Index and thought the CCVI was more sensitive. And we did, as I mentioned, a variety of work around state COVID-19 policies, looking at a couple different other indices, and found that our initial modeling was sufficient. Next slide, please. So let's now talk about the analyses. Next slide. We conducted descriptive statistics for all the variables at the county level, except governance, structure, and state policy environment. Those became state level variables. This is panel data with one observation for each county for each of the 4 time periods. We use hierarchical linear mixed modeling with random intercept for county level data to account for repeated observations and fixed effects for all other variables. And we use an alpha of 0.05 as the significance threshold for all the variables in the model building. Next slide. For each of the models, the multivariate models, we included FAAB accreditation status, time period, CCVI, the state policy environment, and state public health governance structures. These were key variables that we thought would predict some of the outcomes. Independent variables were assumed to be constant within a time period, but varied across time periods. And except for the percentage of adults vaccinated, all time periods were used. And for that percentage of adults vaccinated, time was excluded due to insufficient data. Next slide, please. So let's go to these results. I know you've been dying, like she's killing me with all of this background. Next slide, please. So here are the descriptive statistics, and I just want to note a couple of things. We did see that most of the accredited health departments were in a decentralized governance structure, as you would expect. About the state policy environment was about 50-50. Among percent of vaccinated adults by county, you already see a difference by accreditation status, with accredited health departments having a higher percentage of adults vaccinated. In terms of COVID-19 hospitalizations, for accredited health departments, there is a lower rate of hospitalizations per 100,000, and COVID-19 deaths, again, that death rate is lower among accredited health departments. And again, these are the univariate or single statistics. Next slide, please. I throw this table up here because this is what you'll see in the journal article. I'm going to go through each of these results one at a time so we can dive into them more deeply. Next slide, please. In terms of percentage of vaccinated adults, we found a statistically significant positive association between local health department accreditation status and the percent of county population adult in the county that were fully vaccinated. Among accredited health departments, the county adult population was more likely to be fully vaccinated when compared to unaccredited health departments or health departments that were in the system. Also significant was an increase in over time in the percent of adults that were vaccinated. Interestingly, the COVID index, the COVID community vulnerability index, was negatively associated with the percentage of adults that were vaccinated, but that was not significant. Among states where there was a more restrictive policy environment, there was a higher percentage of adults vaccinated, and there was variation by governance structure among percent of adults vaccinated. Next slide, please. In terms of COVID hospitalizations per 100,000 population, the initial difference that we saw among accredited health departments did not hold in the final models. So we did not see a statistically significant difference in the percentage of adults hospital or COVID-19 hospitalizations by accreditation status. We did see some variation by time, and the only other significant outcome was that among health states with mixed governance structure, there were lower hospitalizations per 100,000 population. Next slide, please. Regarding COVID deaths per 100,000 population, the initial model the initial differences that we saw still held. there were statistically significantly fewer deaths among health departments counties where health departments were accredited when compared to counties where health departments were not accredited or were in the system. We also saw decreases over time in COVID-19 deaths among state policy environments that were more restrictive. We saw a decrease in deaths as well, and there was variation in governance structure by in terms of deaths per 100,000 population. Next slide, please. So we'll do a quick summary, and next slide. So in summary, we found that there was an association between local health department accreditation and improved COVID-19 population outcomes at the county level. There was a higher percentage of adults that were vaccinated, and there was lower death rates. There was no relationship between health department accreditation status and COVID-19 hospitalization rates. And that may be because the models did not control for the number of confirmed COVID-19 cases or vaccination rates. And we saw no differences in outcomes between health departments that are not accredited and those that are in process. Next slide, please. In terms of moderating variables, as you might expect, state policy environment and the state's public health governance structure, we did see in most of the models that these were important variables. The state public health governance structure has been included in many similar studies, and so it's a variable that should be included in studies like this. In terms of state policy environment, there have been more recent studies that have included state policy environment in a variety of ways. And we have seen the impact of state policy on public health outcomes in some studies. Going forward, I think this is an important variable to consider as we continue to do this type of research. In terms of the COVID Community Vulnerability Index, we saw a negative association with vaccine rates and a positive association with death rates. This may be this or social vulnerability index should continue to be a variable included in future studies. Next slide, please. One of our challenges with this study is that there's no national data set of key variables for FAAB related to research. So this required manual building of our data set and will require manual building of future data sets unless a national data set can be prepared. This leads to human errors, inconsistencies in research, and could potentially increase costs. What we would recommend is that there be a future data set that includes FAAB accreditation status, other variables such as FIPS codes, and the state public health governance structure. Also potentially including variables from the NACCHO and ASTO study profiles. Additional limitations to our study is that there's a lack of data to examine vaccination rates as a moderating factor for death and hospitalization rates. So we were not able to include that in our models, and it may have affected the outcomes here. We found significant missing data in publicly available data sets, particularly around hospitalization rates in rural areas. So this significant missing data may have impacted this study and should be something considered in future studies. We needed to simplify some of our independent variables, which may have led to some incomplete findings, particularly the state policy environment. There was a range of data for this, and we chose to go with the most simple approach. And our findings are limited to local health departments, as well as keep in mind these findings are an association and not a cause and effect results. Next slide, please. So in closing, I'd like to talk about implications in future research. Next slide. As we started out, policymakers and the public are eager to understand if accreditation predicts better health outcomes. And results from this study demonstrate an association between local health department accreditation and community health outcomes of increased vaccination and lower death rates from COVID-19. Next slide. And our future research recommendations include creating and validating a national data set for accreditation, validating our findings here. There may be other methods that could build on these findings or at least validate them, exploring other community health outcomes related to accreditation, and getting to that causal relationship between accreditation and better community health outcomes. Thank you very much for this opportunity, and I look forward to the panel discussion and questions.
Yeah. Thank you so much, Mary. And we were just confirming offline, and we can actually take until about 2:45 to do specific questions related to this study. We're going to have the panelists are going to give a greater discussion, but we see some technical questions in the chat that we'll go ahead and address as many as we can and stay on schedule. So the first one, the first question in the chat is, were you all able to see shifts in the CCVI ratings with accreditation?
No, we did not examine that.
Right. It wasn't examined, but how CCVI played into the model was in that first, and everybody will get the slide. But yeah, that wasn't specifically examined. Yeah. Okay. Next question. This looks like a confirmation question. Not accredited means they never applied for accreditation or applied but were not accredited due to certain reasons. Can you explain, or I could explain what your non-accredited kind of grouping was?
Not accredited meant they were never entered into the FAAB system. So for lack of better words, Amy, I would say this is a local health department that just never got engaged with FAAB. In system meant that they had entered into the system and were either in process of accreditation or had gone through the process and not been awarded accreditation. And we, again, through discussion, chose those.
Next question. Did you take into account those local health departments that don't have FAAB accreditation, but had a covering kind of state accreditation, such as Washington and Michigan? I think Mary may be frozen, but I can answer that. Because now 42 of the 50 states are accredited, we didn't feel like that was a helpful variable to include in the model. So no, state accreditation was not looked at, because thankfully so many states have been accredited at this point. What study design did the researchers consider? We might have to get back to you, Jason, on that, but we know how to get a hold of you. I don't feel comfortable answering that one without Mary, but we can get back to you on that one, certainly. That was a pretty technical question about controlling for jurisdictional factors, things like that. So we will get back to everybody and put that in the follow-up document we will create. Is the information in the study embargoed, or can we share data points? Technically, it's embargoed until the manuscript comes out that Mary talked about. So we would appreciate not sharing those. How many departments were included in the study? So that's a great question we get a lot. So the study actually looked at all counties in the United States, so over 3,000 counties, and looked at if a county was covered by a local health department that was accredited or not accredited. So over 3,000 counties were the actual unit of analysis there. See a question about the time period variable. What's the reason for the first time period being when the vaccine was available but limited variability? Why would there not be a time period that measures differences in hospitalizations and mortality? We've gotten that question so far too. One of the studies that Mary didn't mention that came out in the American Journal of Public Health earlier this year, after we'd already started this evaluation actually and developed the methods, used very similar timeframes as those four, so it's pretty consistent. I would say, some of these studies on outcomes around COVID-19, these are some of the first ones that have been done. And so certainly some follow-up work looking at time periods may happen in the future, but that's why that was chosen. Or Mary, it looks like you're back on. Did you want to jump into that one a little bit more about that first time period?
I'm sorry, I apologize. In my rural area, I lost the connection. Could you repeat the question, please?
Yeah. The question has to do with the time period variable. So what is the reason for the first time period being when the vaccine was available, but was limited in availability? And why would there not be a time period that measures differences in hospitalizations and mortality prior to the availability of the vaccine?
I think those are great questions. And, you know, we, as Amy gave you an indication, we had a time limited period for our research as well as limited resources. So I think these would be great questions to explore. We as a team batted around, you know, the various ways to look at this. And I think we chose to go with those time periods because we really wanted to anchor our work in when vaccines started to be available.
Great, thanks. See a great question about there would be a one pager or summary coming out after this. I'll let that be addressed in the fuller panel discussion. Try to stick to some of the ones technical to this. Could greater community support for public health at large, kind of writ large, explain both the higher vaccination rates and accreditation?
I would say yes, you know, and I think it goes back to what I was started out early on with talking about the various domains for in the FAAB standards and measures and partnerships and community support. And I apologize, I should be able to recite all the domains, but I believe in there are partnerships and community support. I think from another study that I worked on with Pima County Health Department, where they engaged community in depth around equitable vaccine distribution, and they are an accredited health department. They really did see, they have one of the highest percentage of adults vaccinated within Arizona, and some huge social vulnerability indices variation in their county. So I think that's an example of where partnerships and community support in an accredited health department situation can really impact vaccination rates.
Mm-hmm. Yeah, it's great questions. Great questions. We appreciate those. There's kind of a lot more coming into the chat that kind of, I think, get beyond this study and definitely things that we're interested in finding out more information on. So with that, we're going to wrap this up. Again, thanks so much to Mary for working with her colleagues at Emory on this evaluation with us at FAAB, and also for presenting today. With that, I'm really excited to toss it over to our FAAB CEO, Paul Kuehnert, to lead into our panel discussion.
Thanks so much, Amy. Really appreciate it. It's great to be with everyone today. And thank you all for being a part of this conversation. Let me just start off by introducing our panelists, who I think probably for most of us really do not need much of an introduction, but we're very thankful that they're here with us today. So joining us, we have Dr. Bruce Dart, who is the Executive Director of the Tulsa City County Health Department. Would also mention that Dr. Dart is a past president of NACCHO and a FAAB member of our board of directors, and also chairs our accreditation committee. Next, we have Dr. Georges Benjamin, who is the executive director of the American Public Health Association. And as we'll probably talk about a little bit later, Dr. Benjamin was really one of the leaders, national leaders in public health that got this whole accreditation, public health accreditation ball rolling, so to speak, following an IOM study. So we'll let Dr. Benjamin talk a little bit about that history and how it connects with today. And then last but very far from least, we have Dr. Judy Monroe, who is president and CEO of the CDC Foundation, and is a past leader, past director of CDC's Office of State, Territorial, Local, Tribal Services. I probably screwed that up because the names have changed, as we know, but CSTILTS, as it was known. And so I'm very happy to have our panelists join us. And I would just ask, we could kind of go around the horn. I'd love to hear your first impressions of what Dr. Davis has shared with us this afternoon, and just kind of get your first impressions. And Bruce, I wonder if we can start with you.
Thank you, Paul, and thank you for asking me to be on this panel. It's great to see everyone. And that the presentation, I think, really corroborated our experiences during COVID. We felt very strongly that we had to be, I think, extra prepared to respond to COVID. People were losing their minds. Remember the fear early on in that pandemic, especially, and because we had gone through accreditation, we had gone through the preparation for emergency response, and we had created new partnerships in the community through our accreditation process. I think we were more ready than other local health departments in Oklahoma, and I felt like we were up to that challenge. Now, no one knew the challenge was going to last three years. But I think because we had prepared, we had gone through things like accreditation, we knew the pressure that I think we were all under, and the fact that the community was looking to us to protect them and to serve them. So going through the accreditation process, I think, really enabled us to have a much better response than we would have had without it. It brought our staff together. It ensured that our staff were prepared to do whatever it took. And the fact that, there's no more guardrails during things like a pandemic, and accreditation assured that we had processes in place that we probably wouldn't have had without it. So we felt very fortunate. In every single article, especially early on in the pandemic, we made sure that they always said Tulsa Health Department, a nationally accredited health department, so that our community could see that we had people here who knew what they were doing, that were there just to serve them, and hopefully help them comfort and help them contact us. And it must have worked because our phone banks, were on 24/7, and we respond to our community, I think, in a way that we're proud to have done.
Thanks so much, Bruce. Appreciate your sharing those experiences. Dr. Monroe, you had a very unique national perspective during the pandemic at CDC Foundation, kind of touching many communities across the country. What are your first impressions from hearing the study today?
Yeah, well, thanks. And I'm really happy to join the panel as well. So appreciate the invitation. For starters, for me, prior to my even coming into public health, I was a residency program director, and we had accreditation, which was really intense. And I was a believer in that process before I got involved as a FAAB board member, and before I oversaw OSTILTS, which was the precursor to CSTILTS. And so my reaction, and I'm just so happy to see this study come out, because we really had a natural experiment, right, with COVID across the United States all at the same time, to capture that natural experience or experiment, if you will. And then to drive toward the actual outcomes. I mean, that's going to be, it's really important. I don't know that anybody can argue with death as an outcome, right? And to be able to show that and vaccination rates, so they're hard outcomes. That was really the holy grail when we started accreditation for public health, was to put in place those standards and that process to influence the outcome. So I'm very happy to see the results. I do recognize the limitations of the study, and I do recognize and happy to hear the report out talking about what we need to do to continue to drive the research around accreditation.
Thanks so much, Judy. Really appreciate it. Dr. Benjamin, again, you have a very unique perspective nationally, and also just in terms of kind of the history of the development of accreditation, not only for health departments, but schools and programs of public health. And also APHA was critical in supporting the development of certification for all of us as individual public health practitioners. So with your history and perspective, love to hear your initial impressions about this study.
Thanks, Paul, and good afternoon, everyone. You know, this accreditation idea came out of the Future of Public Health report, the 1988 ION report. And at that time, there was an issue around trying to make sure people understood public health. As you know, the tagline for that report ultimately was that public health was in disarray. And we were trying to figure out how to make sure that public health mattered. How do we get the public to understand that public health matters? And I think you have to take this study in the context of the series of studies that we have now done to demonstrate that our hopefulness when we started the Exploring Accreditations project, because by the way, we did not have any sense that this would work. There was a lot of controversy, there was a lot of resistance to doing it because, you know, nobody wanted to do one more thing. We had enough to do. By the end of the day, the fundamental question we wanted to ask, does this matter? If you are accredited, does it matter? And I tell people that preparedness is a process and not a point in time. And that as you look at the logic model for accreditation, it really tells you that if you go through this process, at the end of the day, you will have a better product. And then the question is, does that better product actually improve the health of the population? And if you take this study in the context of the other studies, I think we have very strong evidence now that accreditation matters. That if you go through the process and spend the time and effort, that at the end of the day, that you come out with something that actually makes people healthier, that protects the public. And I think my take-home message is, you know, at the end of the day, a very simple message is it works. And I think that's the take-home message from this study. Now, and like anything else, you need more studies, you need more data. We always love to find out more. There are all kinds of questions that we could ask ourselves about why we did this, why we did that. But I do think that the fact that you, in many ways, looked at other potential co-founding things, such as, does the politics of the community matter? You know, as manifested in this scenario by the governor, does the, and by the way, we know from other studies that it does in terms of the outcomes of COVID. You know, we know that vulnerability, communities that are more vulnerable were much more likely to have poor outcomes. But at the end of the day, this study shows that really in many ways corrected for that. So I think that at the end of the day, everything else being equal, accreditation is the one thing that looks like it did the most to improve the health of those communities, to make sure those communities were prepared to address this really tragic event. So, you know, the short version, it works.
Thanks so much, Dr. Benjamin. Really appreciate your reflections and your perspective. And I would just also kind of encourage the participants to go to FAAB's website, faabboard.org, and go to Stories of Impact, because one of the things, and Dr. Dart talked about this, you know, kind of the qualitative experience from the local health director or the state health director's point of view. And in those stories of impact that we have on our website, we have a number of other stories that kind of point to what Dr. Davis was saying about Pima County, what Dr. Dart was saying about Tulsa City and County. And again, these things do kind of fit together, and they help us make sense of what the experience is and how we understand it and how we can, you know, make resource decisions going forward. And kind of with that in mind, Judy, I'd really like to ask you to say a little bit more from your perspective. You were a critical national leader in the project Public Health Forward that was started and funded by de Beaumont and CDC Foundation and others. of a couple of years ago, and then you went ahead with colleagues in Indiana and worked toward implementing those recommendations in Indiana. So tell us a little bit about the background of Public Health Forward, your work in Indiana, and then kind of how you see this particular study that Dr. Davis described as kind of fitting into the work that you've been involved in.
Yeah, thanks, Paul. So Public Health Forward, and a big shout out to all the partners that were involved in Public Health Forward, and the Bipartisan Policy Center was really key with that, along with numerous partners. You know, both Public Health Forward and Health First Indiana, which was Health First Indiana is actually the implementation of recommendations that went forward from the governor of Indiana to the legislature. And then they passed legislation that led to the implementation called Health First Indiana. But if you look at Public Health Forward and Health First Indiana, both of them emphasize strengthening the public health infrastructure, and both align really closely with public health accreditation goals. So that's a starting point. And both of them were aimed toward the improved performance and improved outcomes, again, with what we're talking about with this study. So if to break that down, Public Health Forward focused on modernizing the public health through clear priorities like workforce development, data modernization, and foundational public health services. That was really cornerstone. Those goals align again with Public Health Accreditation Board standards and emphasize performance management and accountability, and focus on on evidence-based practices. Health First Indiana shares a similar vision, and we took that forward in Indiana to look at the standard-based improvement across all the local health departments in Indiana. What the aim of Health First Indiana is to equip local health departments with the resources for them to be able to meet and exceed accreditation standards by investing, again, in the foundational public health services. So they both are really aligned. Another area that they both were very much aligned was data and metrics. Accreditation, of course, emphasizes data-driven decision-making, including the use of metrics to assess health outcomes and program effectiveness. Both of these enhance data capacity, was the recommendation, and in Indiana is being implemented. And of course, you've got to have that. We've got to have strong data systems to be able to track health outcomes and foster that community accountability. Another area that both of them really emphasized was community engagement. And I do think looking at this study results too, when you look at vaccination rates, community engagement is a key component to being able to get folks to show up for vaccines. And so Health First Indiana, as an example, highlighted the importance of meeting community-specific needs. We really focused in Indiana on the local communities and the uniqueness of each local community, and a lot of building trust with public health leaders and other partners within those communities. That certainly echoes FAAB's requirement for health departments to engage in meaningful community partnerships, which I think played out again in this study. And then Public Health Forward emphasized, had a lot of emphasis on equity ties directly to accreditation's focus on addressing the social determinants of health and reducing disparities. So it's exciting to see those recommendations from Public Health Forward being really taken to heart in Indiana, and now Health First Indiana. And I hope everyone follows. You can go out onto Indiana Department of Health. You can go to their or the state health department's website and follow along with what's happening with Health First Indiana. I think they have measures and stories and things that are coming out of each county. So it relates very much.
So all of these things seem to be very synergistic, and I guess what from your experience with Public Health Forward and with the work in Indiana, if you were advising folks that are really trying to tackle these systems issues in a new way, in a fresh way, do you have 2 or 3 kind of key recommendations based on kind of pulling all these facts together at this point?
Yeah, I think of course, every jurisdiction, every state, along with their local health departments, has to start with where they are, and everybody's a little bit different. But I would, given the results of this particular study, I would use this as a springboard to convene at your state and local partners coming together, discuss the outcomes of this study. I think it'd be a great discussion to bring in the recommendations from Public Health Forward and then look at Indiana, as just mentioned. Assess where you are with particularly your local health departments, because we know a lot of state health departments are already accredited, but see where they are in the FAAB process. And then map a plan, and that plan has to include your legislators. If I have one big piece of advice, is find your champions, find those that can be cultivated as champions at whether it's your governor or whether it's the legislators, and make sure that they understand the results of this particular study as well as the others that we've mentioned. I think Georgia's nailed it, right? It matters. Accreditation really matters. And we need, and the building of public health infrastructure really, really matters for health outcomes. I would really figure out a way to drive that home. And there are a number of ways to do the engagement piece of it, whether you're doing listening sessions like Indiana did. We did listening sessions across the state, bring local county commissioners to the listening sessions. I mean, there are a number of strategies that one can have with the engagement.
Thanks so much, Judy. That's so helpful and great advice, I think, for all of us to incorporate. I love the idea of really finding ways to lean in with policymakers and talk about the benefits of public health and do those listening sessions. For sure, that's so important. Bruce, I'm wondering if you can kind of amplify some of this from a local perspective. And I'm thinking, I know I've heard you, I've had the pleasure of working with you for a number of years. And I know I've heard you talk about the benefits that you've seen in the health departments that you've led around kind of changing the culture within the health department. And how do you see that as kind of connecting to these population health outcomes?
That's a really good question, Paul, because when we first decided to go down the accreditation path, we had staff, I think, who were resistant because I think as George just says, it's more work. But I think that leadership really matters, and getting all your staff on the same page is really important. Accreditation really helped us do that in a way that we haven't been able to do that before. We were the 19th health department in the country to be accredited. Our staff were extremely proud of that. They carry that. They also figured out that, and now we have a standard that we have to meet, and we can't be comfortable and complacent. And one of the I think really strong messages about accreditation is that status quo is no longer acceptable. And accreditation drives home the point that status quo is stupid and expensive, and we have to do something different. And people don't like change. But as we go through the accreditation process, we involve all of our staff. They're a part of it. They're invested in it, and they know that they contribute to any outcomes that we have and any positive outcomes that we have. So when you figure out that this is our mission, and our mission is to improve our community, support our community, especially here in Tulsa. We had the worst race massacre in the planet 100 years ago. A lot of our community didn't even know about that because they don't talk about it. While we go through accreditation, we really focus on the equity and disparity portion of the standard accreditation. We have now, that's a story that everyone knows about now. That's a story that everyone's ashamed of now. And we as a community and as a state really are doing everything we can to overcome that. Probably not as quickly as many people would like, but this focus on equality. We had a life expectancy gap in Tulsa that we've lowered down to 8 years. That was 14 before accreditation. So it really gives you the ability to focus on I think on different things that really matter in terms of outcomes, in terms of impacting your community. And our staff, I told them at the height of the pandemic, I've got good news and bad news for everybody. The good news is that everybody now knows it's the Tulsa Health Department. And the bad news is that everyone now knows it's the Tulsa Health Department. We've been here 70 years before that. But, people are very much aware of who we are. The fact that we're accredited, I think we have higher goals to meet, and people expect more from us because people know we are. And that, the fact that Oklahoma City County is accredited, our state health department is accredited, it's helping us form a system, a public health system, which we never had in Oklahoma. And our staff are proud of that, and they're proud to be leaders in that, because we tell all of our staff who works at Tulsa Health Department, everyone here is a leader. And let's set an expectation, let's decide what that means. What that means in terms of your position, in your work, and how you impact those people you serve, and we serve everybody. So it's been a connecting point for all of us. It's given us a rally cry, but we are a accredited health department. We have greater expectations, and people expect greater things from us. So, and without accreditation, I don't think we would have had that. I don't think we would have the ability to respond to COVID-19. I mean, we never looked at things like COVID community vulnerability indexes before pandemic. We didn't look at social vulnerability indexes before the pandemic, and those are things we all pay attention to now. And staff know that very much we look at data to make decisions, and it's supported by what we do. So they don't just come from our guts, which might have been good 10 years ago, but I can't rely on my gut when data tells me their story. So it's been a great connecting point for our agency. We're very proud. Our staff are proud. Staff know that we're accredited. They know we're the 19th department in the country to be accredited, and it's part of what they carry with them every day. So, I hope that everyone would make this decision, because as George said, it's worth it, and it does matter. And it really does produce, I think, an increase in quality outcomes that we wouldn't have gotten without accreditation. So it's been a rallying cry here. And matter of fact, we will resubmit for our second reaccreditation next week. And we've done, I think, great work. We have staff who have really embraced the challenge, and it just flat made us better. And I think I can't say anything more than that.
Thanks so much, Bruce. Really appreciate all of those observations and just the depth of your experience and your department's experience, kind of moving through this process over literally a decade, and then going through the COVID experience as well. Dr. Benjamin, I would be remiss if I didn't state the obvious, and that is that we're in a situation now where the national policy environment is about to change. We have had a national election. We have changes in both the administration that'll be upcoming, as well as the Congress. I'm wondering, knowing that APHA is the organization that all of us in public health look to in terms of policy and having an impact nationally, if you could say a little bit from your perspective, as you've both seen the study, kind of heard the conversation this afternoon, and thinking about the changes in the national political environment. What kind of observations, what kind of lessons are you taking away?
Yeah, that I think that public health has taken a reputational hit over the last few years. And part of the problem is we really haven't been very good at telling our own story. But I can tell you that accountability matters. And when somebody, wants to be tough, and they're going to be the boss, and they come to you and say, I'm going to be tough and I'm the strong man or woman. Then when you can argue that I'm accountable to you, that matters. We often hear from the healthcare side of the house that they have all of these accountability measures. They have the Joint Commission, and they have CLIA labs, and they have all of these merit badges that say that they're excellent at what they do. And then I look them in the face and say, public health we have our merit badges too. We have our accountability measures. We have a Public Health Accreditation Board that evaluates the governmental agencies. And for those entities that are accredited, they have a badge of honor that says they are among the exemplars in our nation. We have a National Board of Public Health Examiners for people who have gone through school and gotten CEF accreditation, who are now saying that I have a piece of paper that says that I have made a certain benchmark. And, in addition to our professional degrees and our, certificates and those kinds of things, we can now say that we have something that not only, is a nice piece of paper that says you put it on your wall, but I can tell you from a political perspective, once you've been accredited, no policymaker wants to lose it. And that's the message is you want to maintain that accreditation because it helps you maintain that standard. And at least it's a differentiator between you and people that have not done it. Then that doesn't mean that you've not done accreditation, you're not great at all. But if you don't have a Super Bowl ring, you can't claim the championship. And so accreditation allows you to say, we've paid attention to this. And I think the other thing that accreditation does is because of the process that we use that brings so many other people to the table, you get enormous community buy-in. So you get other people saying, not just you saying, we're very good at what we do, here are the outcomes, but you get other people saying, by the way, they're very good at what they do because they were part of that process. And so I think that that's something important for us to do. And remember that the original idea for this on the future of public health was for us to be able to engage the public in a more effective way to bring them into our circle so that they see the value of public health and the value of collective health. And I think at the end of the day, the second thing other than it works is that it has value and that it's the best buy. And I think we can make that argument when you've been accredited. And a stronger argument when you've been reaccredited.
Thanks so much, Dr. Benjamin. I appreciate that. And I would just underscore that particularly with the new federal resources from the Public Health Infrastructure Grant, that as you kind of talked about it, accreditation can be accessible to all health departments. We want it to be accessible to all health departments. We know that for many of our health departments, it's really a journey of developing capabilities, developing capacities, and FAAB and CDC, the other FIG national partners, other important national organizations that are in this space, like NACCHO and Public Health Foundation, all of the public health institutes across the country, all of us can kind of work together to help local health departments build those capacities. But accreditation really is that marker of having gone through the rigor of the process, having been evaluated by your peers, and then really having that understanding of where you stand and the ability to kind of talk about that with the community as a whole and with your stakeholders. So really appreciate everybody's remarks on this afternoon. I want to go one more time to each of you, kind of going back to where Dr. Davis ended her presentation. And I'd like to ask for each of you just to kind of share your top one or two recommendations around next steps in terms of research on these questions related to accreditation. So you've heard this first of its kind impact study that took advantage of the COVID natural experiment that we had. But as I listened to Dr. Davis describe the study, there are so many other questions that kind of came up in my mind, and I'm sure in yours, and I'm sure in our participants' minds as well. So, Dr. Monroe, let me start with you. What are the top one or two kind of research implications or research priorities from your perspective that you'd like to see us and others follow up on?
Yeah, so what struck me, we've seen most of the studies. We heard about Zika, in Florida. I think that some of the early indications were that for being prepared for emergencies was something that accreditation really does help with. And now this is a study coming out of COVID. I think we really need to look for other outcomes. What are the other community outcomes that we should be studying, and definitely different ones. But and that might be related to specific communities that have high interest in particular outcomes by their legislators. I go back to that as well. Follow where the policymakers need to see or would like to see the evidence that accreditation is making a difference.
Thank you. Dr. Benjamin, same question to you. What are priority research questions?
Yeah, three. Obviously, the economic return on investment for any of the things that we're doing. Secondly, equity, proving that public health accreditation and these kinds of programs enhance equity in the community in terms of optimal health. And the third thing is I focus like a laser, thinking of the interest in the new administration on chronic disease. Pick the chronic disease of the day that's important in your community. But I think to the extent that you can now replicate a study like this, looking at a chronic disease that's of relevance in your community, I think that'd be a way to go.
Thank you. And Dr. Dart, bring us home. Same question.
Point last, because Dr. Monroe and Benjamin already think my hands. So, thanks, guys. So, I think the bottom line is that we do more work around equity than we ever did before accreditation. And you look at health disparities in vulnerable communities, at-risk communities. I mean, I'd love to know more, do more research around what that means, what accreditation means for those communities, because that's the neighborhoods and communities that need it the most. And we know that here we really feel strongly that accreditation has helped us focus in on some of those long-term issues that we've never even been a part of before. We've never been in the space before. We've never been in conversations before. And now we're talking seriously about how can we as public health entities impact poverty, which we know impacts all of our healthcare outcomes. We never would have had this conversation before accreditation. I would love to have more research around that to see how we can impact those kind of things, because as a community, we're only as strong as our worst off member. And if all of us really want to be global destinations and global communities, we've got to impact those who have the worst in our communities. And I think if we can do more research about how accreditation can help us do that, I'd love to see that.
Well, thank you all so much. This has been a very rich, very robust conversation this afternoon. And I'd like to pass this back to our moderator, Dr. Coleman, to bring us home, maybe bring the other two participants back on stage and see if there's any final questions that are available to all of us. Thank you. Dr. Coleman.
Thank you. Thank you. Very good job. This has been an exciting panel discussion. And I think I speak for everyone. Well, let me just say this. I'm kind of fanning out because not often do you get your favorite public health leaders that you studied about in school all in one place. So I'm kind of fanning out here. So forgive me just for a moment here. But thank you to Paul. Thank you to the panelists. Thank you to the presenters. And now we'll enter just briefly into the Q&A portion of this webinar. And I think someone is going to take advantage of what I just said. You have the top leaders in public health here. So they have a very important question. And I'll start and I'll allow any one of you on the panel or one of our presenters to answer this question. It is, what are the biggest challenges facing public health in the next decade. And so I'll start with you, Dr. Benjamin, and then maybe Dr. Monroe, you can follow up with that.
Yeah, I think at the end of the day, the most important thing is um, making sure that people understand that public health is a top national priority. That encompasses a lot of things we do, but people need to see it as a kitchen table issue, something that and maybe we don't want to use the word public health, but people understand what we do. And the benchmark, by the way, is that when we go home, our own family members know what we do.
Yeah, I would agree with that. I mean, I think our greatest challenge is the engagement of the public, starting with our own families, making sure that they understand. One of the challenges right now, and Paul brought this up, what we must not do is lose the gains that public health has made over the decades. I think that's first and foremost. Let's not lose what we've gained. And then we've got to take on some major issues, such as climate and health. We've got plenty of issues that are coming at us that must be addressed. And I see over the next 10 years, these being really big.
Yeah, I agree. And I wrote down, as a communicator, I always look for sound bites. If you don't have the Super Bowl ring, you can't claim to be the champion. So I wrote that down. I'm going to use that in some form or fashion. Dr. Dart, I'm going to turn to you for this question. How does public health accreditation foster trust and accountability within communities? This is a question as a public information officer, or at least a former public information officer, during a very trying time in public health back in 2002. I found this to be the question then, and I certainly find this to be the question now. So what is your response to rebuilding or building trust in public health and its connection to public health accreditation?
We never stop building trust in public health. Every day is a different day. There's circumstances that occur in your communities that impact people's trust or perception of you and your organization. So that's work that never stops. And I think we can never get complacent about, oh, we're here every day, we're doing our job, so the community must support us. I think it was Dr. Monroe who mentioned about community engagement. We've become much, much better at engaging our community, mainly because, in public health, we're so arrogant. We're always showing up saying, hey, we're public health, we know what you need, we're here to help you, as opposed to asking community members what is it that they need in their neighborhood, in their lives, in their families, so that we can do the right thing for them and not waste time, and not have a cookie cutter approach to everything we do in public health, because each unique community, each unique neighborhood needs something differently. And if we can be there for their specific issues, we're going to build trust organically. And it's something we can never stop doing. Trust is something that can be enabled in a second and broken in a second as well. So it's work that never stops. And for us, it's showing up every day. It's doing what we say we're going to do, and it's being respectful of the public and public perception of who we are and what they need. And then including our elected officials, which we know how political public health is, but we have to confront it. We can't run away from it, and we have to be the first voice to respond to negativity out there. Because if we're not, we're the only voice there. So pay attention, get involved, don't run away, and take risks. If you do all those things and you do it consistently, trust might be attenuated, but it'll never be gone.
Yeah, thank you for that. I think this question, I'm going to actually combine these. Given the findings, what do you see as the next steps in the research in public health, the next big thing in the research public health and accreditation? And so I'll just turn that over to Amy and to Dr. Davis. What do you see as the next big research project that should be conducted related to public health accreditation and public health?
I'll let Dr. Davis follow up on kind of maybe potential next research steps related to her study. I would, and I've seen some of this in the chat, I think our next really big push at FAB is to really try to get our handle on how to frame return on investment. I don't think, it's kind of return on investment. I don't think accreditation was ever done to provide a return on investment. It was there to improve organizational effectiveness and performance management. And it's so hard to tease out what health departments have done when they develop a culture of accreditation and performance improvement, what's exactly due to accreditation and what's not. But so ROI is a challenge, but we know that is something that's needed by the field to really associate impact with accreditation. And so we are this year's impact evaluations. We are looking a bit more into that in both return on investment models and social return on investment models. And I saw in the chat too some requests for some kind of plug and play tools for health departments to be able to put in their jurisdictional data and get out information for their jurisdiction. And that is actually one of the things we're looking at for the ROI tool, is some sort of kind of plug and play tool. So I'll say from FAB standpoint, we have a lot of questions, but I would say that's the one I would focus in on. But would love to hear from Mary more about the COVID study and future directions.
Thank you, Amy. And I agree with you. There's been a wonderful plethora of ideas that have come through the chat. And I also offered, my initial thoughts at the end of the presentation. And, I think Amy and I have talked about building that FAB data set. And I think to do all of these studies, that's the critical next step. While I have the open mic, I do want to take a moment, Keith, to come back to your challenge of the next decade, one that I didn't hear. And I was kind of having a moment of reflection as I'm looking through whose names are coming through the chat, and some of them, including all the way back to Ron Bialik, who I was at Hopkins with, as he was on faculty when I was a student there too many years ago. But I'm seeing a lot of our stalwarts, the names that I recognize in this chat. And one thing we haven't talked about is the workforce. And at Emory Centers, I've had the pleasure of working with graduate students, young evaluators, new folks, and bringing them up through, learning the ropes of how to work in public health. And I think one of our biggest challenges is making sure we continue to build that pipeline. Because as we know, we've had very worn out people who have worked through very difficult circumstances leave the field, and we need to build that next generation.
Yeah, and I was actually going to go there. So I was going to put our leaders on the spot. Maybe they can elaborate more in terms of public health, the workforce, this study, and let's hear. Maybe Paul, you can kick us off. What does this mean for the workforce, and how can lessons learned be applied for the future leaders and existing leaders within organizations?
Yeah, thanks. I'd love to build on that. I do think I hearken back to one of the comments that Bruce made, that accreditation really is a leadership issue. And the reason it's a leadership issue is that it's making a value statement about our organizations and our workforce, and the value that we place in providing the highest quality services possible to our communities and serving all of our community members. So I think it's a very, very powerful tool. As I talk to students from a variety of backgrounds and experiences, having a way to really kind of organize and think about this big, huge thing that public health is really important. And I think that accreditation gives us a way to organize that in terms of a framework, and also to really unify as a common set of purposes and objectives. When we work at a governmental public health agency, we really are working toward a common set of outcomes, and we kind of see that manifested in the standards, measures, the domains that help us organize around the common work for the benefit of our community. So I think it's really something that's very important as a way to help organize our workforce as new folks come in and really kind of identify it as we've been talking about, building that culture of public health that's a commitment to service, a commitment to quality, and really a commitment to partnership with the community.
Certainly. Anyone else? Workforce implication or insights into the workforce and perhaps future studies here?
You know, since COVID, I think we look at workforce development completely different than we ever have. Our staff are the future of our organization. They're also the future of our community. And so we have to function at a high level every day. And I always challenge our staff to bring their best every day. If they don't, do better tomorrow. And so we're focused more on developing them as public health professionals and giving them the ability to advance and go wherever they want and do great work. So we have an emphasis on professional development that we've never had before and that they can take advantage of. I think the FIG grants have been tremendous in that capacity, but once the FIG grant runs out, we have to carry that work on because the FIG grant has shown us how important that work is. So we have to figure out how we find the resources to continue organizational development and workforce development forever. Because that's how we're going to impact our communities. That's how we're going to be the best agencies we can be. And so it's an emphasis that's taken on a measure of importance that, you know, was always there and always in front of us, but it's much more critical now.
Yeah, appreciate that. And we are just about at time, but I do want to close with one question. And this is a question that keeps coming up. I've heard it as a communicator, but just as someone in the community. And it's really about the application of what we learn from this study and what we've seen over the last few years. How do we sell public health? What do we say to the public as well as elected leaders about the value and impact of public health accreditation? And any insights that you can share with this group in terms of storytelling, in terms of messaging to elected leaders and decision makers. And so I'll start with you, Dr. Monroe, and then we'll go to you, Dr. Benjamin.
You know, I would share, going back when I ran OSTELTS, we had the National Public Health Improvement Initiative, which was a precursor to a lot of what's happening with FAAB. And what was remarkable about that, because we had performance improvement managers and really looked at, actually Ron Bialik worked with us, and we worked with APHA and ASTO and NACCHO on all of this. And what was remarkable were the number of conservative policymakers that took note that the health department was improving efficiency and effectiveness. Some of them got state awards. Hawaii got called out. I mean, there were stories that came out of that. So I think there's a story that needs to be packaged there for certain policymakers.
Yeah, I go back to the original definition of public health, what we as a society do to achieve optimal health, and make sure that everyone understands that's our vision and that public health is a community asset. Unlike other governmental agencies, not to separate us apart, but we are one of the few agencies that is truly there as a community asset for everybody. And I think that what makes us a little different than some of our other colleagues. We partner with them. They're part of us, but everybody's part of the public health family.
And then Paul, I'm just going to turn to you for any closing remarks, and then we'll close this out.
Well, again, I want to thank everyone on the panel, as well as our colleagues from research that have been so instrumental in making this conversation happen this afternoon. Also want to thank everybody that participated in the lively conversation in the chat. And this is one of the things that I just absolutely love about public health is we really are a large community of very diverse experiences, and we bring it into these conversations and learn so much from each other. So at FAAB, our mission is to be a part of that, to advance and transform public health practice by championing performance improvement, strong infrastructure, and innovation. And accreditation is really the cornerstone of that mission for us. As we've talked about this afternoon, accreditation fosters trust and accountability within our communities. It ensures that health departments meet rigorous national standards and are committed to continuous improvement. And so really want to thank also the CDC for funding this important set of studies that we were able to conduct over this past year. And just want to make sure that everybody in the larger public health community knows that we at FAAB are there for you and want to be a part of supporting you in your journey to excellence and resilience as we all work together to make it possible to have everyone in our diverse communities thrive and have the healthiest lives possible. So thank you all very much.
Yeah, so thank you, Paul. And Paul is retiring. And so what a remarkable career. Congratulations to you, Paul. I can tell you, I can speak for myself, but I can speak, I'm sure others feel the same way. Thank you. We really appreciate what you've done for public health. So thank you. Before we conclude, I would like to remind you of some upcoming FAAB events that might be of interest to you. Utilizing Services and Resources webinar, December 11th at 3 p.m. Are You Ready for the Future of Public Health, which is co-presented by the Institute for the Future on December 12th at 11 a.m. And then Service and Research Sharing Approaches, Focus on Data Modernization, Part 2. December 17th at 3 p.m. We encourage you to participate in these events, to continue the conversation going, and to stay informed about the latest developments in public health. Once again, thank you to our presenters, to our panelists, and to all of you for your active participation. The recording of this webinar will be available on FAAB's website soon, along with the additional resources that we mentioned. Have an amazing day. Thank you, everyone. Bye-bye.